And thank you, Amy, for the kind introduction. These are a list of my disclosures. I have many relations with companies that are involved in developing advanced therapies. The outline of today's presentation is we first need to define what does it mean to, quote, have advanced, and quote, Parkinson's disease. And then we're going to dive into some of the therapies that are available with a more deeper dive about MRI-guided focused ultrasound. It's also termed focused ultrasound or high-intensity focused ultrasound. So first off, there's no clear definition of what it means to have, quote, advanced Parkinson's disease. However, one common definition that most groups use is that of an individual having motor complications. Now, what are motor complications? Motor complications simply means that the individual has either motor fluctuations and or dyskinesias. And this is in the context that the individual still has motor complications despite, quote, optimize, again, very subjective term, pharmacological treatments. So what are motor fluctuations? I think you guys have heard about this earlier on in the course of the day, which is the individual has medication, they feel really good, they're feeling, quote, on, meaning they have low amount of Parkinsonism, low amount of rest tremor, rigidity, slowness of movement, and postural instability. That goes on for about 3-4 hours, and then boom, all of a sudden they go off, meaning, whoops, the Parkinsonism is coming back. They take a dose of medication. It takes about 30 minutes or so for the medication to kick in, for them to feel good again. And they do this up and down kind of throughout the day. And that's what we term as motor fluctuations. Then what are dyskinesias? Dyskinesias, as you see here, are involuntary, abnormal, unpredictable, writhing-like movements. And they can vary in intensity, but they tend to be these peak dose dyskinesias that tend to involve more the head or the one side of the body. And so this is an individual, for example, with dyskinesias. The most important point here is to determine if these are bothersome to the individual. A lot of the time, the individual might be making these movements and he or she is not even aware that they're making them, okay? So in that context, we simply provide reassurance and not necessarily make even medication adjustments. And you can see these writhing-like movements simply of the left hand, a little bit of the shoulder, head, and of the leg. When did these motor complications occur during the course of the disease? If we look at motor fluctuations, nearly 100% of individuals will develop motor fluctuations within 10 years from the disease onset. And at about 50% or so will develop motor fluctuations by about 5 years. If we look at dyskinesias, slightly lower, about 50% of individuals will develop these type of dyskinesias at about 10 years, okay? So when you think about those numbers as we continue on. So what are these advanced therapies that we're referencing? We're mainly talking about any type of treatment that's not oral medication, okay? And you can see there's a number of different names for these: treatments for advanced Parkinson's, advanced therapies, interventional therapies, device-based therapies, surgical treatments. They're all referring to these type of treatments, and we'll cover these in the subsequent slides. Specifically, we'll cover drug delivery systems, and then also we'll jump into the surgical treatments. So when do we start talking about these treatment options? Well, if you were to hear me say by 5 years in the disease course, an individual might be developing motor fluctuations and or having even dyskinesias. So we end up talking about these treatment options much earlier in the disease course. Okay, this is an elective brain surgery or elective treatment, so we want to make sure that our individuals, our patients, are well informed and have ample time to actually think about these. If we wait until the individual is off the edge of the cliff, it's already kind of too late. You can't buy back time. The individual has already given up, for example, hobbies that they like to do: woodworking, fly fishing, hiking, playing with the grandkids. We could have done these options, these treatment options, much sooner in the disease course, so the individual still could maintain that form of personhood, i.e., who and how they identify with themselves. So we're going to jump right in to talk about the drug delivery systems to start with. So the first one is called carbidopa-levodopa enteral suspension. It's also called levodopa-carbidopa intestinal gel. It's also called duopa. It's also called duodopa. They all mean the same thing. What this is a gel form of carbidopa, levodopa that's connected to a pump. This is about the size of two TI-81 calculators. So it's a fairly large pump. This then has a tube that goes into the stomach. And within that tube, within the stomach, is another tube that delivers the gel of levodopa, carbidopa right into the small intestines. Okay. It's approved for daytime use only, so 16 hours, and it's approved for, quote, advanced Parkinson's disease. This is a very effective treatment. It reduces off time by about 4 to 5 hours, okay, and improves on time without having troublesome dyskinesias by about 4 to 5 hours. So quite effective. The downsides. It's a fairly large pump, okay, and it's got this heavy gel that's connected, wearing it around all day in a fanny pack. It's also only approved for daytime use. I will say most of our patients, a number of them have it being used for 24 hours. So we use it for off-label use as well. And a lot of issues that are resolved around the tube itself. So irritation around the tube, infection around the tube, leakage around the tube gets pulled or pulled out. These are common issues. About 75% of individuals will develop one of these adverse effects at some point during the treatment. This is a new guy, hopefully, on the block, and most movement disorder neurologists are really excited, and patients are also excited for the day, hopefully, that this comes available, hopefully next year. This is subcutaneous carbidopa levodopa. So this is a liquid form of carbidopa levodopa, and you can see the size of the pump is quite a bit smaller. This is very similar to somebody that has diabetes, and it has an insulin pump, okay? So this is basically a sticker that gets put upon the skin that has a very small needle. Think of a needle like 6 millimeters, okay? That delivers in a drip form, the liquid form of carbidopa levodopa over a 24-hour period. In 1 to 3 days, the person removes the sticker and puts the sticker in a different part of the abdomen or thighs or up on the deltoids on the shoulders, for example, okay? The aim is that this will be available for 24-hour use, okay? So the individual, if they don't like it, they just take it off. This is not a surgery. The data is very promising thus far. You can see here on time is improved by about 4 hours, okay? So, and this is in comparison to best medical treatment. The adverse effects are related to the skin itself. So skin irritation, worst case scenario, infection. There can be some pooling of fluid under the skin. We commonly will have our patients take it off after 2 days, and we have a lot of hygiene with regards to how you maintain the area that you're going to be applying basically the sticker with the needle. So let's jump into the neurosurgical treatments. First of all, to be able to provide neurosurgical treatments, you have to have a large team. Okay? And this is our team here at the university. We've got a number of individuals within each one of these disciplines, and we really can't function without having everyone doing their job. We're going to first talk about MRI-guided focused ultrasound, but I think it's helpful to have this treatment discussed in a historical context, okay? So I'm going to be talking about radiofrequency ablation briefly in gamma knife therapy, and then we're going to dive into focused ultrasound thereafter. Whenever we're talking about Parkinson's disease, we think about 3 areas of the brain, okay? There is the subthalamic nucleus, and then the GPI, or globus pallidus internus. Those are areas of the brain that we tend to target for Parkinson's disease. Those are areas of the brain that we perform DBS on. Those are areas of the brain that people might be investigating with regards to focused ultrasound or high-intensity focused ultrasound. Another area of the brain is called the VIM, which is a nucleus of the thalamus. This is a very good area for targeting for tremor. However, the STN and the GPI are both very effective targets for tremor, as well as rigidity and slowness of movement. So the main thing I want you guys to remember is ST and GPI, good for a number of Parkinson's symptoms. The VIM, or thalamus tremor, okay? So thalamus tremor, TET, okay? Historically, one of the first treatments that was available is radiofrequency ablation. In this surgical treatment, what occurs is that an electrode is provided deep to a target, okay? So this involves a burr hole, an electrode going down, and what they do is deliver radiofrequency waves to the tip of that electrode, which creates heat, and then that burns that portion of the tissue. Once that's done, they remove the electrode, close the skull, close the skin, okay? This really became less attractive with the advent of DBS, where people said, well, why don't we just leave an electrode actually in there, which can provide us with a lot more added benefit. Then we have gamma knife radiofrequency surgery here. So gamma knife surgery, you might have heard with regards to cancer treatment, and it is widely used for this. This has an advantage is that there's no incision provided, and you're providing radiation waves that converge and go upon one single point, okay? And this then causes the tissue to die off. And so you're able to deliver something where you're not having to actually open up the skin and create a burr hole. So that's a major advantage of this treatment. It's also fairly effective, as you've seen these numbers for tremor. But the problem with this treatment is that we can have something called runaway lesions. So you wanted to create a small lesion like you saw before with the radiofrequency ablation. But in this context, we actually created more radiation and we've got a runaway lesion. So we're actually having death of tissue more than we had wanted. The other major problem is we don't see the results, the clinical benefit, until about 5 months or so after. So you go into the surgery, we say, well, hopefully this worked. We'll see you in 5 months, okay? MRI-guided focused ultrasound, it's also termed high-intensity focused ultrasound, also termed focused ultrasound, really combines the benefits of those two treatment surgeries that I just talked about, radiofrequency ablation and gamma knife surgery. In this surgery, what we do is we have all these ultrasound waves that converge upon a common point. And there's over 1,000 of them, 1,024 ultrasound waves provided to the individual through this hemisphere, okay? If you have all these converge upon one point, that creates heat. And we can measure in real time what that heat is. And we can increase and decrease the power to either increase or decrease the heat. And we can turn off, turn on different, we call these elements, to steer that heat map. The advantage is, again, just like you saw with gamma knife surgery, that it is incisionless. There's no incision here. But the benefit that you saw with radiofrequency ablation is that the benefit we see is immediate. We don't have to wait 5 months, and we can see in real time that heat that we create. This is FDI approved, you see, for unilateral procedure for essential tremor back in 2016, and just recently for bilateral both sides of the brain. However, we have to wait 9 months between the surgery. So if we want to, for example, the person's right-handed, we do the left side of the brain, we have to wait 9 months to do the other side of the brain to treat the left side of the body. It's also approved for tremor-dominant Parkinson's disease. And you'll see here the caveat with regards to insurance coverage. We often can get this approved for insurance. And then also you'll see here for Parkinson's disease, it was recently approved, although it's not approved by insurance. And we'll cover it as to why that might be. And what are the benefits? Well, first of all, to have actual good success, you have to have appropriate patient selection, and you have to have good surgical targeting. When we talk about patient selection, obviously you must make sure that the individual has the correct diagnosis. I've seen patients that come in for this and they actually have a psychogenic tremor. Okay, this is not a good treatment for psychogenic tremor, for example. When the individual says, hey, my medications for essential tremor don't work, and I see the patient, I go, well, they don't work because you actually have Parkinson's disease. So you have to make sure that they have the appropriate diagnosis. They also have to have realistic expectations. So nothing's 100%. So if you have somebody that's a fine painter, for example, I'm not going to be able to make that person be able to paint in such great detail like they did when they were in their 20s. Okay. So we have to have realistic expectations saying, okay, we can improve your tremor by about 70%. So you're able to feed yourself, bring the glass up, etc. But these things that you used to be able to do still might be a challenge to do. Another point here is they have to have an appropriate skull. And what do we mean by that? Well, ultrasound waves like to go through hard material. Think of like redwood, okay? They don't like to go through softwood like cedar. If they go through softwood like a sponge, they get absorbed in the skull, and that creates heat in the skull, and that's painful. And those ultrasound waves then don't necessarily get to their actual target, or they get diverted. So the individual has to have a hard enough skull for those ultrasound waves to make it to their target. There's some other points here. If they have significant gait impairment, I might be a little bit more concerned about this, or I might certainly change how we target. And there are some general things that we also must consider. If they're very claustrophobic, the individual is getting an MRI and will be in the MRI machine for a period of time. We often can work through that. If they can't remain still for a prolonged procedure, and the procedure takes about an hour and a half up to 2 hours. Obviously, and if they can't get an MRI because of certain metals. And you can see here some other points here with regards to age. So I'm going to walk you through one of our patients who went through this. This is an individual with essential tremor, not Parkinson's disease, however. He's a 71-year-old right-handed gentleman. He had a significant amount of postural tremor, and you'll see that in a minute. You can see here that he's got a lot of tremor with regards to performing these Archimedes spirals and in trying to perform a straight line from point to point. He's been on a number of different medications, and his main goals, see, this is what I mean by realistic, ability to use utensils, drink, perform basic woodwork, and he wanted to improve his dexterity to be able to fly fish. So this is an example where he was starting to have to give up one thing that he loved to do, which was fly fishing, because he wasn't able to actually perform it. Now the target, this is for tremor, okay? The target, again, was that VIM, the nucleus of the thalamus. And here he is. So you can see he's got a high amount of tremor really with that right hand. Again, this is essential tremor. But you can imagine this also in somebody that's got Parkinson's disease who has what we call tremor predominant Parkinson's disease. And it basically renders that hand very difficult to use. And this is him trying to write the sentence. And that's his signature. Now, here at the university, we have a number of different techniques that we use to make sure that we either put an electrode exactly in the right location, as well as also in this context, when we're performing MRI-guided focused ultrasound. We use indirect coordinates, so you can take a point from here to here, and X amount of distance over from this point, and that might be your place where you put the electrode or you create your burn. A number of places do that. We also have a mask, meaning an atlas that is superimposed specific for that individual, okay? So this is a computer-generated atlas that says, hey, based upon everything that the computer can determine with regards to the patient's brain, it suspects that this in pink is the area that we want to target. We also use something called tractography, okay? In tractography, we can look at the tracts that come, for example, from the cerebellum up into the thalamus, and that's being shown in gold. And those are the tracts that we want to be able to ablate or lesion. We also can see tracts that we want to avoid, for example, the motor tract here, the cortical spinal tract, as well as the sensory pathway. These are places that we certainly want to avoid. Okay? So it gives us a good idea about where we want to target. We combine all three of these techniques to actually make sure that we're really targeting exactly where we want to be able to create that lesion. That's all done ahead of time. During the day of the surgery, I might repeat some portions of the neurological exam. We get IAP access, and the reason why is because I give the individual Tylenol and Zofran, also known as ondansetron, to prevent any form of nausea. This is a big caveat for some of our patients, and in my experience, particularly for women. The head has to be completely shaved. And I mean like shave cream, Bic razor, completely shaved. And the reason is because I don't want the hair to catch fire. It tends to be bad, as well as any type of diversion of the ultrasound waves. A head frame is placed. So these are basically screws that we just tighten into the skin itself. Okay, so think about putting a pen right to your skin like this. Okay, we numb up the skin. Okay, there's no incision or anything like that that's created. Then we have the silicone membrane that we tighten over the head, as you see, and you'll see why that is in a subsequent slide. And then we position the individual on the scanner. There is a lot of prep work to do this. There's over like 28 steps to be able to get to the point where you're performing the ultrasound when I'm delivering those ultrasound waves. So the individual gets basically an 8 to 10 minute MRI, and then we pull them out and they're still on the table while I'm doing all this work in trying to merge different images, align different images to make sure everything is accurate before we actually perform what we say is the sonication. Sonication meaning when we're delivering the ultrasound waves. When we finally get to the point of being able to deliver the ultrasound waves, this is what we can see. You can see here the heat map that's generated, okay? And if this heat map is a little bit beyond the area that we want to target, we can adjust that in real time. So we can move this. So we make sure that we're seeing areas that we want to target and avoiding those other areas. And we have our tractography lined right up with this and merge with this. So I can see, is this encroaching upon areas that we want to avoid? We also assess the person during real time. So in this, I'm looking for any adverse effects to start with, any sensory loss, motor loss, any changes in coordination. And obviously, then I'm also looking for clinical benefit at this point in time. The other point is you can see that the individual, this is the head frame, and this is that diaphragm, okay, that rubber-like diaphragm. And that's connected to this, which is the transducer. You can think of this like a 1940s salon hair dryer, and that's what's delivering all these ultrasound waves, okay? Between this membrane and this transducer is circulating cool water. Okay? Anyone that's had an ultrasound knows that you have to put gel. Ultrasounds like to go through a liquid media. They don't like to go through air very well. So this is cold circulating water to make sure the skin and the skull remain cool while we're delivering the ultrasound waves. An individual might have up to anywhere 6 up to 9 sonications. That's when we're delivering the ultrasound waves. The reason is the first 3, the 4 are what we call alignment. So I'm looking at that heat map in X, Y, and Z planes, i.e. 3D space, to make sure that everything is aligning up correctly. The temperature is low, okay, up to 45 degrees Celsius. Tissue tends not to completely burn until you get up to about 56. So all we're doing at this point in time is making sure everything aligns correctly, as well as that we're seeing any clinical benefit or adverse effects. We're stunning the tissue at this point. Nothing we've done here is really permanent. So I'll pull the person out and I want to see, do we see some clinical benefit and am I causing any adverse effects? After that, then we'll do a slightly higher amount of temperature. So I'm getting to temperatures that I really want to see a clinical benefit and make sure I'm also not inducing any adverse effects. And once we've done that, then we'll do a treatment. And that's when I'm really creating that burn. So the minimum number of sonications someone would get would be 5, right? So there'll be 3 that are just alignment, 1 that's let's make sure before we create that burn, and the final one in which we do create that burn. So let's see what happened with our patient. What you can see is Archimedes spirals to start with during the pre-op. And then after he's had his alignment, I did 4 alignments at this point in time. And you can see here there's a benefit with regards to the performed Archimedes spirals that here compared with in his pre. Okay, so this tells me that this looks like a promising area of the target. He had a total of 2 different regions that we did target. And at this point in time, tremor's pretty much gone. He does have some slight coordination impairment. That's not uncommon, and that tends to resolve. After we're done with that procedure, we pull him out of the MRI, we take off the membrane, the head frame, and everything else. And I do have him get a quick MRI after. And the reason is because I want to see where that hole is. I want to line that with my plan and see how well did we do. Again, here is that cortical spinal tract. That's where I want to avoid. Here's a sensory pathway. We want to avoid that. In gold is the tremor tract. That's the tract we want to be able to knock out. That's the tract we want to hit. Okay. And this is simply subtracting that gold tract here. So you can see, yes, indeed, we created a hole. That's good because we want to create a hole. We want to ablate that tissue. We don't just want to create a stun effect. The person feels really great. And we say, well, in 2 weeks, sorry, once the edema swelling goes down, it's all going to come back. So we want to create that hole. And we can also see how much swelling might there be. So he encroached a little bit into that sensory pathway. And that's not uncommon because of how close we are here. That resolves. So after 2 weeks, he had a little bit of, it feels just a little bit different. That went away. And here's him thereafter. So you can see the right hand is what was treated. Okay. And he has no longer does he have any tremor here. Again, we didn't treat the left hand, however. And this is done the day after. So the patient comes in, we perform the procedure. I will, after performing the procedure, watch the patient for a couple hours, and then they go home. And then I see them the next day. And this is what we can see. So this is the before and the after pictures. For essential tremor, we get about a 70% improvement of tremor. Okay, that's pretty good. When we look at the actions, what they perform, pouring, writing, 40% improvement. In addition, disability is improved by over 40%, and quality of life is improved by about 30%. This is sustained up to 5 years, at least with the data that we have now. So this isn't something that's temporary, transient. This seems to be pretty long lasting. It's a similar story when we look at tremor dominant Parkinson's disease. So if an individual says, I only have this right hand tremor, it's really bothersome for me, the medications work well, otherwise, that's the only thing I want to be able to get rid of is this tremor, this might be an option. Knowing that, hey, your rigidity is still going to be there, the slowness of movement is still going to be there, and you're probably still going to be on medication because the medication is helping for all those other symptoms, which this would not necessarily treat because we're only targeting the thalamus. Again, that area of the brain responsible for tremor. When we look at the adverse effects can be broken down into those that occur during the procedure itself, and those that can occur thereafter. So during the procedure itself, there can be pain, okay, and there can be risk of nausea associated with this. And the individual also could be kind of cold. Why? Because we're, putting cold circulating water around the head, and the person's losing a lot of body heat. Those are kind of discomforts during the procedure. Afterwards, it all depends upon if we made extra careful sure that we really avoided those areas of the brain. If we encroach a little bit too far lateral or left or right, we can get weakness. If we go too far back, we can get sensory loss. If we go too far low, we can get gait impairment or coordination deficits. But there's been, even when you read that literature, there's a lot of changes that have occurred with regards to how we're performing the procedure. We used to try to get the temperatures over 60 degrees. That creates a big lesion. So of course you're going to encroach upon regions you want to avoid. Now we tend to get to about 56. We also noted the number of sonications. You can see here we do about 6 to maybe 9 sonications. If you look at the original literature that's now quoting the adverse effects at this point in time, they were even up to 16 sonications. So of course you're going to create a greater lesion than you had intended. We also have changed our targeting to avoid areas that we want to avoid, and we've incorporated, at least in our institution as well, tractography, which we think improves our accuracy. So great, you talked to us about tremor. What about those other 2 areas of the brain you told us about, that STN and GPI? Those are those areas of the brain that can also be helpful for the rigidity, the slowness of movement, and the tremor. Oh, that's more important for Parkinson's disease. The study just was reported with regards to targeting the pallidum, okay, or the GPI. And unfortunately, the results were not very exciting. 30% of individuals did not even have a clinical benefit. So if I was to say, hey, we're going to do this elective brain surgery, and there's a 30% likelihood you won't have any benefit at all, that's kind of a hard sell. Okay. In addition, when we look at what was defined as a positive response, it was a really low bar. It was 2 points different on a scale. So others have also commented that doesn't necessarily mean that that's really a functional improvement if the individual only has a 1 or 2 point improvement on a scale. Despite the lack of clear clinical benefit, it was, however, fairly safe. So there were a low number of adverse effects. All right, well, what about the STN? Well, the STN is kind of just the opposite story. We see about a 40% improvement, up to 50% improvement in those symptoms with Parkinson's. So it looks really promising, okay? Again, this is an incisionless procedure done on one day, person's admitted, goes home that day. So it looks really, really good, 40, 50% improvement. But again, it's just the opposite. It's the adverse effects that were quite a bit high for targeting the STN with focused ultrasound. You can see here dyskinesias were quite common, speech impairment, and most importantly, especially in our patients with Parkinson's disease, gait impairment. So the adverse effects were quite high with regards to doing focused ultrasound on the STN. So in general, what are the benefits? Well, this is a surgical treatment that's incisionless, no incision, outpatient. Come on in, do the procedure, you go home that day. You're awake the whole time. We can see in real time those thermal measurements. We can perform a number of tests to make sure that we're targeting that area exactly as we want to and avoiding other areas. And you get a physical examination between each one, and the results are immediate. Okay. What are some of the concerns? Well, if your targeting is off, you can have expansion of the lesion beyond where you want. You can't really adjust it, only burning more tissue once you've done so. What's done is done. It's non-reversible. And there are still some concerns about doing a bilateral procedure. Again, this is just only recently approved, so we'll wait and see what are the longer-term outcomes of this. This leads us to deep brain stimulation. The rest of this talk is going to just basically kind of cover this, okay, in the context of providing a complete advanced therapies talk. I'm not going to dive too much into DBS. You all know that this has been around for well over 20 years. This involves placement of electrode into one of those 3 targets that we talked about, with a cap that goes to a connection wire that's positioned under the scalp to a battery that's just above the clavicle. You saw a very similar slide before when we talked about focused ultrasound, but in this, now you see the success is dependent upon programming. If the individual doesn't know how to actually perform programming, then it doesn't matter, even if you're a great patient and it was a great surgery, your outcomes are not going to be as successful. The patient selection is very similar to what you've heard already about focused ultrasound. There are some caveats. If the individual has cognitive impairment, this is a concern. And the clinical benefits that we can see with targeting the GPI, as well as the STN, is predictive of the benefits that the individual has with carbidopa-levodopa, with the exception of tremor. So tremor might not fully respond with carbidopa-levodopa, but it does respond very well with DBS. There are some other surgical concerns as well. If the person has a lot of what we say atrophy or loss of brain matter, tumor, or a history of bleeds, then this might be a surgical concern, which renders an individual likely not an ideal candidate for this procedure. And as an example, we had an individual who did have quite a bit of brain atrophy, loss of brain volume, and we were concerned about doing brain surgery, i.e. DBS, on the person, but he was a really good candidate for focused ultrasound and went in for that because this tremor on one side of the body was his main symptom. You already saw that one slide where you saw all those different fields that were involved in our team. And we have all of these individuals involved in the evaluation of a patient. We all come together 7 o'clock on Tuesday morning. We have what we call a patient care conference where we talk about the individuals from the week before to determine if we think that they're a good candidate or not. There are 3 in the United States, 3 DBS companies. You've met probably some of them here today. I'll point out we're not on contract with any company, and we implant all 3 of them and program all 3 of them. And there are different nuances between each one of them, why one individual patient might select one over another, and we walk through and talk with the patient with that. Then we have surgery. There are 2 different head frames that we do use here, and it depends upon the surgeon. We've improved also, as you saw already with tractography, but also have improved the visualization, for example, here of the STN, with some of our novel sequences. I hope you can already appreciate that we all work as a team. So in this example here, you have one of our neurosurgeons and one of our neurophysiologists working together to determine if they agree with the day of surgery, the exact plan targeting. So the next couple of slides, I'm going to bring you actually into the operating room. So if you're a little bit squeamish, as you heard Dr. Amaro say, now is a good time to kind of close your eyes a little bit. So an incision is made and a burr hole is then created. Burr hole meaning a small hole in the brain. This is about the size of a dime, between a diamond and nickel, okay? That's not the size of the electrode. The electrode size is anywhere from 1.26 to 1.36 millimeters. This allows a cap to be able to put on that anchors that electrode. So it's not like you have a hole in your brain after. There's a cap that goes on top of that. You can see we tend to perform also microelectrode recordings. So we place a small electrode, much smaller electrode, down to find the target, okay? And the tip of that is anywhere about 0.1 millimeters. So that's a very small electrode, a hair. And that allows us to hear different parts of the brain to make sure we're in the exact area of the brain that we want to be in. And you can see that as an example here. After the electrode is placed and we verify that's where we want it, we remove that small electrode and then we place the DBS electrode. So let's see if you can hear this. Volume. in this example, this person's awake. There's two tracks, one here and here. So two electrodes on this side. Bottom one is pretty flat. That doesn't look like that's an ideal track. At the top one, A is responding to him making movements. So that's a motor addition. Be able to see, at least you can see, that tremor cells. Those correspond directly with the tremor that he has in his hand. Okay. So you don't have to be a doc to say, gee, that seems to be a good area of the brain to be able to target. I'm hearing cells correspond directly with my arm tremoring. In addition, as you saw from the imaging and the microelectrode recordings, we also had lead confirmation. So afterwards, we evaluate and see how well did we do with placement of that electrode, and do we have all those contacts? An electrode that has about anywhere from 4 to 8 contacts on it. Are those exactly where we want them to be within our planned target? The last part that I mentioned was regard to programming. So we have to think about an electrode has got lots of different options, different contacts. It's got different amplitude and frequency and pulse width. And you can shape a field of stimulation. And that's mainly what we think about. How can you shape a field stimulation so that you're stimulating areas of the brain that you want to, and you're not stimulating areas of the brain that you don't want to? And success of this is highly dependent upon the individual performing the programming. Some basic reasons why you might not have the greatest benefit: misdiagnosis, IOVO context not selected, the volume of tissue that is being activated, that means the shape is not great enough, or the electrode is not positioned in the right location. If you end up having too much of stimulation, we can reduce the amplitude, the pulse width, or you can change context. So it's very adjustable. So an example, an individual says, hey, I got some pulling in the mouth right now. I go, okay, change it. Oh, yep, it's gone. Okay, it's instantaneous like this. So what are some examples of success here? This is an individual off of stimulation. And you'll see when I push the button here, and now he's on. And you can see the remarkable benefit that he has. And you can see he's quite a bit slow here, and then you'll see when he's doing the pronation and supination a little bit. Clinical benefits, we see notable improvement of rigidity, anywhere from 50 to 75%. Slowness of movements about 50%. Tremor can be improved dramatically, 75% plus. The dyskinesias can also be reduced either directly because of the target or because we've had to reduce medication by about 50%. There's also notable improvement in quality of life, like you saw in MRI-guided focused ultrasound, where improvement about 20–40%. Memory and sense of motivation, i.e. apathy, really do not seem to be improved. So the person goes, look, my memory is really kind of what's mostly bothering me. This is not a good treatment for the individual. The risks, well, any brain surgery does carry a risk of death. There can be intracranial complications such as a brain bleed, a lead revision, or it can be actually hardware is getting exposed. There also is a risk of any hardware in the body and risk of infection. So how the heck does one choose? Well, This is why we talk about these things very early, much earlier in the course of the disease, right? Because I don't want somebody to come in and say, hey, we have to make a decision sometime soon. You're already losing things. And this is already brand new. We want to have plenty of time, months, years for the individual to talk, learn about them, go to talks, talk to other individuals. In addition, there are specific treatments that might be better for one individual and not for another. And I do think the future is going to be that we don't just think about one treatment. We're going to be combining treatments. So we might combine, for example, DBS and subcutaneous continuous infusion carbidopa-levodopa. That might be an ideal treatment for a number of individuals. So it's not just going to be a winner take all, in my opinion. Some points about ourselves: we're the largest comprehensive movement disorders team for advanced therapies. We have great collaborations amongst all the members. We have licenses in New Mexico, Colorado, obviously, and Wyoming. We can program and implant all DBS devices. We use, I think you saw some novel techniques to improve our accuracy. We have a huge number of research trials. I think you've heard a little bit about that earlier today. We also have neurogenetics and neuropalliative care also involved. This is a list of some of our direct contact information. And Mari, who I think is in the back, she is our nurse navigator, and she runs all of our ATMD programs. So if you have any questions at all, she is the face and voice of our program. Happy to take any questions that you have, or wait thereafter to take questions as well. Thank you very much.